I'm Dr. Lindsay Van Dyke. Today we're going to talk about thyroid surgery. Surgery is an option to treat Graves' disease if other treatments have failed, or the patient is unable to take the medication or is uninterested in radioactive iodine treatment. This is always going to be a complete thyroidectomy. Surgery is also the cornerstone to treating all forms of thyroid cancer, and in the majority of cases, this does involve a complete thyroidectomy. Although for certain variants of thyroid cancer, sometimes only one side of the thyroid needs to be removed. Sometimes surgery is used to treat just a large goiter with and without nodules that causes compression of the airway or esophagus or is impinging on the vocal cords. This is also almost always a total thyroidectomy. Specific details about risks, benefits, alternatives to surgery are always a dynamic conversation between the patient, the ear, nose, throat surgeon, and the endocrinologist. But here are some general points to be aware of. Risks. There's always going to be some risk of infection or bleeding with any surgical procedure. Your parathyroid glands can be disrupted during a thyroid surgery. Your parathyroids are responsible for managing your body's calcium levels, and this is discussed in detail in a different podcast. If the parathyroid glands are disrupted during surgery, it can result in severe low calcium levels. This can be an emergency, but usually it represents the fact that the parathyroids kind of went into shock after surgery, and they resolve themselves. Rarely is it permanent. Surgeons are very careful and they're very good at identifying and preserving those parathyroid glands, but we watch the calcium very closely after surgery. Vocal cord paralysis can occur during thyroid manipulation because the recurrent laryngeal nerves do run through the gland. If this happens, it results in a permanently hoarse voice. Surgeons are very careful to identify and protect the nerves during this surgery. After removal of a thyroid, and this is extremely important, the patient absolutely must take lifelong thyroid hormone replacement because thyroid hormone is vital for life. If you do not have a thyroid gland, you cannot make thyroid hormone, and if you can't get thyroid hormone from a pill, you do die. It is a process that happens slowly, but it can become an endocrinology emergency. What are the benefits to a thyroid surgery? Well, if you have Graves' disease, your symptoms are going to resolve, and it's much easier and safer to take thyroid hormone replacement than it is to take methimazole or PTU to try and block the overactive thyroid gland. If you have a cancer diagnosis, having the total thyroidectomy allows the pathologist to chop up that thyroid gland and look at it under a microscope, and this will help them accurately identify the stage of disease so the endocrinologist can determine if additional treatments are required. If you have compression of the airway or the vocal cords, this will resolve with recovery from your surgery. What are the alternatives to thyroid surgery? Well, of course, a patient always has the precious right to choose no intervention. In the setting of cancer, there is no alternative to surgery because we cannot accurately stage or treat the disease without a pathology report. In the setting of Graves' disease, medication or radioactive iodine treatments are the alternatives to surgery. In the setting of a large compressive goiter, sometimes it can be shrunk by appropriate hormone treatments, if that's applicable. Otherwise, there are no alternatives. Patients always ask, how big is that incision? Usually it's quite small, maybe a couple of inches. I actually had a thyroidectomy in 2002, and until I tell my patients about it and show them where the incision is, they can't tell. For advanced cancer surgeries, or especially large goiters, the incision can be quite large around the neck and extend up toward the angle of the jaw. This depends on the surgeon's recommendations and the needs to explore the other compartments in the neck, like if they're looking for metastatic cancer. How long is the recovery from a surgery? Well, typically people are out of the hospital in 1 to 3 days. In fact, it's really rare for someone to stay longer than one night unless there's a problem with those parathyroids. The full range of motion and the resolution of pain can take a few weeks, and the tissue around that incision is going to remain firm, almost woody, for weeks to months, but eventually it does heal and go totally back to normal. Okay, so let's pretend you've had a total thyroidectomy. How long do you have to take calcium and thyroid hormone? The calcium is usually normalized within 2 to 4 weeks, but that levothyroxine or that T4 replacement is for life. Let's talk about the hormone options here. Levothyroxine is the generic medication for human thyroid hormone, T4. It is synthetically produced, but it is identical in structure to the hormone your body produces. Your body is extremely good at converting the T4 to T3 as needed. This is mediated by a special type of an enzyme in every cell of the body, depending on your body's needs. There are extremely rare cases of patients who are deficient in that enzyme, but they are so exceedingly rare, I have not seen one in real life. Armour thyroid is another option for thyroid replacement. It actually is a ground-up, dehydrated pig thyroid gland, so the hormones are not, in fact, identical to human hormone. They do cross-react with our hormone receptors. It's a little harder to adjust Armour thyroid because each pill can have different amounts of T4 and T3 in it. We can't predict that, but overall, it works fine. Liothyronine, or T3, that's the active form of thyroid hormone, is only used quite rarely. Specific situations because the body's so good at converting T4 to T3. If we use T3, it can increase the risk of heart palpitations and thin bones. All right, how do patients take thyroid hormone? Well, there are some rules. So if you're going to play by the rules, you take it on an empty stomach with no other medications or food for at least 1 hour. Levothyroxine, or T4, is very stable. It's a very long-acting hormone, so the most important thing to remember is that you need to take it the same way every time. We can adjust the dose according to your body's needs. Because some patients take so many medications, it's impossible to take one of them by itself on an empty stomach. And so we adjust those doses. If you forget a dose, you can take 2 of the pills the next day. Certain medications and foods can interfere with T4 absorption. Classically, these are vitamins and minerals like iron, calcium, vitamin D. Dairy foods can do the same thing. Medications like omeprazole or Nexium can do that, and there are a number of others. So if you take any of those things, you should separate them significantly from your thyroid hormone. And I recommend to patients that they take their thyroid hormone in the morning, and they take the other stuff after dinner. How do we know if treatment is adequate? Well, after treating with levothyroxine for about 6 to 8 weeks, we check that TSH and the free T4 again. And let's talk a little bit about how thyroid hormone signaling works. The signal begins in the pituitary gland that makes the TSH, or thyroid-stimulating hormone. Its job is to ask the thyroid gland to do its job and make T4. When it does make T4, that amount that circulates around in the body feeds back on that pituitary gland and it shuts off the TSH signal. So in a case where somebody has had a total thyroidectomy, they can't make any thyroid hormone. So that TSH number will get bigger and bigger and bigger as it begs and begs and begs for more hormone. So when we're giving adequate amounts of T4 replacement and we measure that TSH, we know it's adequate when the TSH goes back to its normal range. If that TSH signal is too small to measure or that number is suppressed, then the dose is too big and we need to back off a little bit. So in the cases where even when biochemically the TSH and the free T4 are right smack in the middle of normal and the symptoms are persistent or the patient is insisting they feel poorly, they're tired, they're gaining weight, etc., we have to go back to the drawing board and start thinking about other reasons for a patient to have those symptoms. And again, for certain thyroid cancers, we will adjust that dose of levothyroxine to target a very specific TSH because TSH is kind of like a growth factor for thyroids. So if we've had cancer, we want to minimize that risk of recurrence by suppressing that TSH. If you have questions, you can use the following resources. I trust these sources. They are peer-reviewed and up-to-date and written in normal human-style English. So you can start with the American Thyroid Association at thyroid.org and the Mayo Clinic at mayoclinic.org and search for thyroidectomy. You can learn about ear, nose, throat surgeons at entnet.org thyroidectomy.org.